to North of 60. I'm Heidi Schweighofer. Today my guest is Dr. Schmidt from Western Reserve Vision Care here in Hudson. I happen to be a patient there as well, and I am delighted that they are able to send someone and Dr. Schmidt can talk to us about everything that's going on with aging eyes. Dr. Schmidt, thank you so much for coming.
Well, thanks for having me. I'm excited to be here.
Now, tell me first the difference between a doctor of optometry and a doctor of ophthalmology.
Sure. So I'm a doctor of optometry, and one of the big differences is with our schooling. So we both need a bachelor's degree, and then after that, I went to optometry school. That's a 4-year program. A doctor of ophthalmology, they instead go to medical school. They have further training to specialize in ophthalmology, and some continue onwards and specialize even further into different areas like glaucoma, retina, pediatrics, and things like that. So we can both prescribe glasses, contacts, diagnose and treat eye diseases and conditions, prescribe medication. One thing that ophthalmologists can do in addition to that is surgery. So cataract surgery, LASIK, things like that.
Okay.
But a lot of us work together closely. I co-manage a lot with ophthalmology with those patients that do need surgery. And so we're very good at kind of sharing the care of our patients that way.
Okay. I've always wondered that because I never have thought it mattered, and I thank heavens haven't needed eye surgery yet. So, but speaking about that, now let's talk about older eyes. And I know that my husband had cataract surgery, and other people I know, it seems like right around 60, 65, 70 cataracts show up. I want you to tell me the cataract story. What are the symptoms? What actually happens to the eye, and does it get worse? Does it get better? Let's talk about cataracts.
Sure. So I like to say cataracts are like gray hair and wrinkles. If you collect enough birthdays, we're all going to have them. So it's a normal aging change that happens to all of us. Usually in the 60s is when I start seeing cataracts in almost all of my patients.
Really? Almost all? Okay.
Yep. And what happens is inside the eyes, we have a lens. As when we're young, that lens is nice and clear. As we age, there's proteins that become damaged and clump, and that causes some cloudy areas in the lens. When that happens, that's what a cataract is. So as that slowly progresses and gets worse, and the cloudiness in the lens increases, it can start affecting your vision. So typical things people may notice are going to be with glare. So nighttime driving, halos, starbursts can get worse. Blurry vision, the vision may look hazy, filmy. Some patients notice that colors may look more dim or faded as well. So cataracts are going to happen to all of us. Usually by age 70, most of us are having cataract surgery, but I've had patients in their 50s have surgery. And I've had patients, in their 80s that haven't had surgery yet. But
is there a cause? I mean, I've always heard you need to wear sunglasses when you go out and you're young. Is there a particular cause that would make someone in their 50s have cataracts versus someone in their 80s, or is it just the way it is?
So most of it's aging, but there are things that can increase your risk of getting cataracts earlier in life and then having them progress and worsen more quickly. And those are smoking, exposure to UV light, like you mentioned. My patients that have medication that is steroids chronically for some conditions can have cataracts happen sooner. And then my patients with diabetes can have cataracts happen earlier and get worse more quickly as well.
Oh, I didn't know that.
So UV protection, is important not only for your skin, but also for your eyes as well. But ultimately, none of us will escape cataracts. It will be something that we deal with at some point, but those are things that can increase your risk and make them happen earlier in life.
And it would be through a visit to you that you would be able to tell me, okay, you've got them started. What is the, when I see you next, if you tell me I have cataracts starting, how many years do I have before I have surgery? Or again, is it just through my yearly visit to you that I'll find out?
Yeah, so having a dilated eye exam is important because that's the best way to look at the lens and see if there are cataracts starting. As far as how quickly those progress, your guess is as good as mine.
Oh.
They could get worse in 6 months. They could take 10 or 15 years to be bad enough that we're talking about cataract surgery. So I usually say just once a year your annual dilated exam, but if you're noticing changes sooner, blurry vision, glare, seems like your prescription's not working anymore, then it's a good idea to come in earlier and we can see if those cataracts are progressing and getting worse.
And then you refer to the doctor of ophthalmology that you're associated with. My husband's experience with the surgery was, as we were talking about, it was more time in the waiting room beforehand and then in the recovery room after than the surgery. I had barely gotten my coffee before he was ready
Yes.
to come back out.
So when the cataracts are bad enough where it's interfering with your ability to do your normal daily activities like driving, reading, I refer you to an ophthalmologist, one that does cataract surgery. And during the procedure, they remove that cloudy lens, that cataract from your eye, and an artificial implant lens goes in its place. Now the cataract surgery itself takes about 10 to 15 minutes. It's an outpatient procedure, so you go home right afterwards. The recovery is fairly quick. Within a day or two, most people are seeing very well afterwards.
What about if you wear glasses now or contacts? Will I be able to see without my contact lenses or glasses?
So that artificial lens does have a prescription to it.
Oh,
So
cool.
they can correct for nearsighted prescription,
Yay.
farsighted. They have lenses that correct for astigmatism. They even have multifocals that can correct both your distance and your reading.
No kidding.
And some patients aren't wearing glasses at all after cataract surgery or very little prescription
Or just
compared
reading
to what
glasses,
they had before.
maybe.
Or
Oh,
just
how
readers.
lovely. Can you show me on your eye what exactly is you're talking about with
Sure.
the lenses?
So if this is your eyeball, I'm going to open you up here. This is not at all like what they do with surgery.
It's a
The
good
front
thing.
of your eye has your cornea here. I'm going to remove that. This is your iris, the colored part of the eye. And right behind the iris, you have your lens. So this lens is what is usually nice and clear, but is what's becoming cloudy when you have cataracts. So all light that goes into the eye and goes through this lens gets focused back here in the retina. So if this is cloudy, all the light passing through it gets scattered, and that's why you have more glare. It gets blurry and harder to see, and that's why changing glasses out here doesn't always work, because it doesn't change how
Right.
light has to pass through that lens.
Okay. And so in the surgery, they take that lens out and put the new super lens in. And it's about a 10-minute procedure, you said.
And there's no sutures. The incisions they make on the front of the eye and the cornea, and those self-seal, so there's no stitches to be removed later or anything like that.
How very cool. All right. I told you, and I'm aging myself, that when I was a nurse 300 years ago, we were keeping people in the hospital for 5 days, absolutely rigid without their head being allowed to be moved. Boy, what a difference this is.
A little different now.
That's wonderful.
Technology's improved a lot.
So, okay, let me ask you about this. If you have issues, so first you're going to find out if your patients have cataracts, how it's going, whether or not they need surgery. What if their eyesight continues to progressively get bad? They have the cataract surgery, but I know my father has been diagnosed with macular degeneration. I'm not sure what that is. I know there's a wet and a dry. Tell me now about that.
Sure. So macular degeneration is another common condition I see in older patients. That and cataracts are kind of the two big ones. Macular degeneration is when there's deterioration of the retina, and it's in the area of the retina where we have our central vision, which is called the macula. There are two types. There's a dry type and a wet type. With the dry type of macular degeneration, you have some thinning and some atrophy of that tissue in the macula.
Now show me again where the macula is.
It's not easy to see here, but this orange tissue along the inside is your retina.
Okay.
And right near the centers where you have your macula,
Okay.
which is your central vision.
Okay.
So that's what you're using when you are trying to read words on a page, see someone's face, fine print, there we go. Anything in that central part of your vision. So with the dry type, there's changes in that area. There's thinning of the tissue. You can also have drusen, which is an accumulation of some protein and fat in that area. And as that accumulates, it affects more and more of the central vision. The dry type is more common. Probably 80% of macular degeneration patients have the dry type. The wet type is a little bit less common, and people with the dry type can convert to the wet type as well. The wet type of macular degeneration can include those same things as dry macular degeneration, but then there's also new blood vessels growing beneath the retina, and those leak and they bleed and they hemorrhage, which can cause further damage to the macula.
Yuck. Is that why it's called wet? Because
of those
oh
blood
my,
vessels.
is that painful?
No, these patients don't feel it. It doesn't hurt. You know, they may have some visual changes like blind spots in the vision, blurry vision, things like that, but they usually don't feel it. There's nothing that hurts that tells them that something is wrong.
So they know it by a loss of vision. Even now, can someone have cataracts and macular degeneration?
Absolutely.
Oh, for heaven's sakes.
And then at that point, it's hard to say how much of the change or loss
Yeah.
of vision is due to one or the other. But with cataracts, when you have the cataract surgery, that cloudy lens is out of the way. So then we, deal with the macular degeneration kind of after that.
And does everyone get that as they grow older? It seems again like, my father's in his 90s. Many of what friends he has left seem to have some form or another or some level of it.
So no, not everybody gets macular
Oh,
degeneration.
good.
Some people can have a few drusen or spots, very, very mild presentations. That's not uncommon. But my patients more at risk of getting macular degeneration have family members with it. Smokers are at an increased risk.
Well, he smoked.
UV exposure
Really?
can damage that tissue and put you at a higher risk. Caucasians are more at risk. And then patients who have high cholesterol or diets with a lot of saturated fat and things like that.
No kidding. I've always wondered what, now that I look at this, he's been a smoker, is a smoker, even at age 99, certainly is on cholesterol medicine now, but all of the things that you just mentioned seem now to, he can see, but he can't read anymore. And he talks about having very little peripheral vision. Is that what you have heard?
So typically it's going to affect the central vision.
Oh.
So when you're trying to read fine details like reading, it'd be like putting a smudge right in the middle of your glasses. So usually these people still have good peripheral vision.
Maybe he's telling me the opposite because he just got confused.
Possibly.
So that's why he can't, because he used to be a reader and now books aren't.
So these people can be legally blind, even though they still have quite a bit of peripheral vision. If you lose enough fine detail, that can keep you from driving, from reading,
Sure.
from recognizing people's faces, anything
Sure.
you use your central vision for those fine details.
Now, let's move on to the next thing that I have heard about.
Okay.
Retinal detachment. All right, so now I know someone, of course, who has had that happen to her husband, and he had to like sleep facing downward or upward, or he had to put his head down for 5 days or something. It sounded awful because it didn't sound like one could do much with that. Talk about that and tell me what's being detached.
Sure. So a retinal detachment doesn't affect everyone.
Thank heavens.
But, if we're looking inside the eye, this orange tissue here on the inside is your retina. What can happen is that tissue can detach or have a tear where that tissue moves forward, and then its blood supply underneath, it is not attached to that, and so it's not getting blood flow and oxygen to that tissue. So just like anything else, if you're not getting oxygen, that tissue starts to become damaged, which means you're losing vision in that area. So symptoms you may have if you have a tear or detachment of the retina would be a whole bunch of new floaters. Any flashes of light, those are usually going to be out in your peripheral vision, or anything like a curtain or a veil coming down over the vision.
Is it sudden?
It can be sudden. A lot of times these happen out of the blue for some patients. Obviously, any head trauma or eye injury, can cause a tear or detachment.
Sure.
But for a good majority of people, they kind of just happen on their own without any
for
good
heaven's sakes.
reason why.
You can't escape this stuff. Boy, okay. And then what is the deal with you have to face forward or down? And I'm not making fun of it at all. It was just, sounded very difficult for a short period of time.
So our goal, and at this point I refer you to a retina specialist, you see an ophthalmologist for this. At that point, depending on where that retinal detachment is and how severe it is, and if your central vision is still maintained, the treatment varies. So it may be as easy as a laser procedure in the office if you have a small tear or detachment.
Okay.
If it's something a little bit larger, they may need to do surgery. A lot of times with that surgery, they are in different ways pushing that retina back up to where it's supposed to be attached.
Oh my
And
heavens.
as that heals for a week or two, in order for that to stay attached, your eyeball needs to be pointing downward, so you may be face down during that time. You can get up to use the bathroom and things for minutes at a time, but the good majority of your time and sleep is spent being face down until that retina heals back into place. So if you see any of those symptoms,
big sleeping
don't
pills.
wait. Please call us. We dilate your eyes and check the retina and see if anything's going on that needs to be addressed.
Oh my heavens! So any kind of bright lights or big time floaters or nothing? Okay. Can I ask you about my number 4, and that is glaucoma.
Okay.
I again have family members who have had it, and I know it has to do with pressure. That is all I know. And I know that when I was visiting you, I had a glaucoma test prior to seeing you in your office, though. So what exactly is that?
So with glaucoma, I'll show you my eye here.
Okay.
This is your optic nerve. This is where nerve fibers from your retina leave the eye and go back to your brain. Then you also have blood vessels that come in and give oxygen and blood supply to the tissues of the eye. With glaucoma, you're having damage at the optic nerve and lack of oxygen and blood flow. And so those nerve fibers that are leaving the eye and going back to the brain become damaged. Those don't come back or regenerate, so this damage is permanent. And typically, the nerve fibers that are first damaged are going to be the ones responsible for your peripheral vision. So kind of the opposite of macular degeneration. These patients start losing peripheral or side vision that can slowly progress more towards the center of their vision.
Oh my heavens.
So having an increased eye pressure can cause glaucoma, although some patients with what we consider to have a normal eye pressure can still have glaucoma as well. I have patients with higher eye pressures that don't have glaucoma. So it's kind of what eye pressure is okay for your eyes, but we look at the eye pressure as one piece of information. We look at the optic nerve and might do some scans to see if there's areas of damage or thinning there to determine if there's glaucoma as well.
Can you do this in an office visit? If I had normal pressures, can you also see my optic nerve in the examination you do?
Yes, so when your eyes are dilated, we're looking at all the structures on the inside. So we're looking at the lens for cataracts, we're looking at your macula for macular degeneration, we're looking at your optic nerve to see if there's any abnormalities there, and then it also allows us to look at all areas of the retina to see if there's any tears or detachments going on. So your
Jeez.
yearly eye exam, we're checking all of those different things all at once.
I feel like I should be seeing you about every 2 months because it's scary. You know, I think of the things that I could, you know, that happen as you get older. And for me, because I'm such a reader, it's my, you know, I have been from the time I think I was born. I can't imagine not being able to read. That would be awful for me. And all of these things sound like they could impact that ability
Definitely.
And the only one that sounds like it's easily fixed is the cataract surgery. The
Yes.
rest, what does one do for glaucoma? Let's say it's due to increased pressure.
Okay.
Is there a treatment?
Yes, so right now the only treatments we have for glaucoma are to lower the pressure inside the eye. Our thought is if we lower the pressure inside the eye, more blood supply can come to the optic nerve and keep that tissue healthy. So different ways we can lower the eye pressure. Usually first we have eye drops.
Okay.
There's a few different eye drops, and we can use those in combination as well to lower the eye pressure. There's also laser procedures and surgical procedures that a glaucoma specialist can do if we further need to lower the eye pressure. Say if the drops aren't working or you forget to put them in, they don't work if you don't use them. So
Right.
if you aren't compliant with using your drops or medication, there's surgical and laser procedures that could possibly be done instead.
Okay.
So we start treatment and then we kind of monitor your optic nerve and hopefully things kind of stop progressing. But if we see further damage down the road, then we know the treatment's not working and we need to do something further.
Do you have any sort of, I don't want to call them takeaways, but sort of a final, what we should do, what I should do at my age to promote and maintain eye health? Like 2 things or 3 things, or
Sure.
what do you think?
So I guess my big points would be with a lot of these eye conditions, not smoking, UV protection, and then just living a healthy lifestyle. My patients that have high blood pressure and diabetes can have a lot of issues with the eyes. If you're overweight, if you don't have a good diet, if you don't have exercise, a lot of those things impact not only your body, but your eye health as well. So just keeping yourself healthy, having a healthy lifestyle, a good diet, and then
Controlling
sun
your blood
protection and
pressure.
not smoking
right.
can go a long ways to keep the eyes healthy.
Thank you for coming. Every time I go to a physician, I want answers, and about so many things. And I have really, truly been so curious about all of these because they are terms that I hear thrown around that I know family members and friends have had, and maybe you will discover them in me when I next see you, Dr. Schmidt.
We'll find out.
So we'll find out. And I really appreciate this. Thank you so much for coming.
Oh, well, thanks for having me. I enjoyed our conversation.
Me too. If you want any information about reaching out to Dr. Schmidt or the Western Reserve Vision Care, you know that you can send me an email at north of60hctv@gmail.com. And thank you so much for watching.